Assalamualaikum. Today our topic is dysmenorrhea. Dysmenorrhea literally means a difficult monthly flow or painful menstruation, but in clinical practice, pain is often accompanied by other symptoms. So, according to the book Arshad Chauhan, dysmenorrhea is defined as a symptom complex consisting of crampy lower abdominal pain, mainly occurring during menstruation, radiating to the back and legs, often associated with GI, cardiovascular and neurological symptoms, as well as general malaise. So this is the definition, the accurate definition of dysmenorrhea, and how you are going to answer the definition of dysmenorrhea in your viva, OSCE and exam. So this is the definition of dysmenorrhea. What are the types of dysmenorrhea? Basically, there are two types of dysmenorrhea: primary dysmenorrhea and secondary dysmenorrhea. So first of all, we are going to study primary dysmenorrhea. Primary dysmenorrhea is said to be primary. Dysmenorrhea is said to be primary when it occurs in the absence of a detectable organic pelvic pathology. On diagnosis, on investigation in primary dysmenorrhea, we never see a cause, we never find a cause, an organic cause or an organic pathology based on which we can say that this is the cause of the pain or this is the cause of dysmenorrhea. So there is never a detectable organic pelvic pathology. So this variety is much more common, right? It is much more common in young women and teens. Up to 72% of teenagers experiences some discomfort during dysmenorrhea, while 3 to 10% suffer from dysmenorrhea, severe dysmenorrhea, and it starts within 1 year of menarche. What is the pathogenesis for primary dysmenorrhea? Primary dysmenorrhea is essentially idiopathic, right? And is accompanied by normal pelvic examination. As I told you earlier, there is no detectable organic pelvic pathology, so it is often accompanied by normal pelvic examination, and a number of theories have been put forward to explain a possible reason for primary dysmenorrhea, but none of them is comprehensive enough to be the sole etiological factor, right? So some of the pathologies are increased myometrial contractions, right? Increased myometrial contractility. According to this theory, okay, according to this theory, the primary dysmenorrhea is a result of uterine hypersensitivity. The uterus is hypersensitive, and there is uterine hyperactivity, and increase in the uterine contractility can be demonstrated by measuring the intrauterine pressuring during menstruation. So according to the to increase myometrial contraction theory, it is due to uterine hyperactivity. Then the second theory is decreased uterine blood flow. This theory suggests that dysmenorrhea may be an ischemic type of pain. Right, ischemia is very painful, so dysmenorrhea can be an ischemic type of pain which occurs due to decrease in the blood flow to myometrium, okay, and myometrium, perhaps because of increased myometrial contractility. Due to increased contractility, there is a decrease in the blood supply to the endometrium, so there is an ischemic type of pain. Then we move on to the third theory, which is the progesterone. Oh, sorry, this is not progesterone, it is prostaglandin. Prostaglandin, PGF2 alpha and PGE2. Okay, I'm sorry for the mistake, but it is prostaglandin, and prostaglandin F2 alpha and prostaglandin E2 are present in menstruating endometrium and menstrual fluid in high concentration, right? So as you can see here, that prostaglandin E2 alpha and prostaglandin E2 are present in my menstruating endometrium. Prostaglandin F2 alpha stimulates myometrial contractility both in vivo and in vitro. Okay, and prostaglandin F2 increases the sensitivity of nerve ending to other pain producing substances. As a result, the prostaglandin synthase inhibitors relieve dysmenorrhea. So if we give prostaglandin synthase inhibitors, so they can help relieve dysmenorrhea. Okay, then the fourth cause is ovarian hormone. Fourth theory is ovarian hormones, ovulatory cycles, and ovarian hormones affect both uterine prostaglandins contraction and myometrial contractility. Then cervical stenosis. The idea behind cervical stenosis theory is that we say that perhaps the women with primary dysmenorrhea have some kind of obstruction to the flow of menstrual blood, but histosalpingographic studies performed during menses has failed to show any increase in the tightness of cervical canal in women with dysmenorrhea. So cervical stenosis is of doubtful importance. Then vasopressin is maybe one of the cause at is a powerful stimulant of non-pregnant uterus, and its plasma concentration is higher on day 1 of menses in dysmenorrheic women. Then the next is the neuronal pain. Okay, the stimulation of nerve endings which are present in the myometrium and the cervix, they can produce more pain and dysmenorrhea during menstruation. Then what is secondary dysmenorrhea? Okay, a secondary dysmenorrhea is defined as painful menstruation which is secondary to recognizable pelvic pathology or dysmenorrhea, which appears in patients who have experienced painless periods for some years during the reproductive age. Here in secondary dysmenorrhea, there is a cause of the pain. There is a proper pelvic pathology which is further diagnosed, which is treated, and the pain is relieved. So secondary dysmenorrhea is secondary to a pelvic pathology. What are the causes? As you can see here, the congenital abnormalities. In the congenital abnormalities, this rudimentary uterine horn is one of the cause, right? Rudimentary uterine horn is one of the cause. Imperforate hymen is another cause, right? And let me zoom in this diagram. Okay, so that I have drawn this diagrams because it is easier to remember things that you see in a diagram or with different colors. So that is why I have drawn this diagram. So the congenital causes are the rudimentary uterine horn and the imperforate hymen and transvaginal septum. These three are the congenital causes. What are the acquired conditions? The acquired are fibroid uterus, endometrial polyp, pelvic inflammatory disease, adenomyosis, ovarian tumors, cervical stenosis, intrauterine contraceptive device, and endometriosis. These all are acquired conditions which can cause secondary dysmenorrhea. Okay, moving on. Basically, secondary dysmenorrhea occurs in association with a number of congenital and acquired pelvic pathologies. As I told you earlier, the congenital abnormalities are rudimentary uterine horn, imperforate hymen, and transvaginal septum. And the acquired condition within the uterine cavity are the endometrial polyp, intrauterine contraceptive device, adenomyosis, uterine fibroid, cervical stenosis following surgery. And outside the uterus, the causes are endometriosis, pelvic inflammatory disease, pelvic adhesion, pelvic congestion, and pelvic tumors. Moving on to the diagnosis of secondary dysmenorrhea. Okay, first of all, history is the most essential part of any diagnosis, and it leads us towards the diagnosis, right? If you take a good history, so you may have a base idea of what further investigations should be performed, what further examinations should be performed in a patient who comes with secondary dysmenorrhea. What are the history questions? Some of the history questions which may help you in your history are that: when was the onset of the pain? Does the pain radiate? What is the type of the pain? Pain is same since the first time she had menses, or has it changed since menarche? Has she used any painkiller? And if she says yes, so what type of medications she has used, and how many times a day? Has she tried local heat, and was it effective? Is her sleep disturbed? If her sleep is disturbed, it shows the severity of the pain. And are there any other associated symptom and history of any intrauterine devices? Moving on, examination is performed. General physical examination is done. In general physical examination, if a patient has severe dysmenorrhea and any proper disease due to which she has had heavy bleeding as well, so anemia can be seen. The patient may be pale looking and is in severe pain. Okay, then we perform abdominal examination and pelvic examination. Pelvic examination should not be performed in unmarried girls unless it is really important, and even then special consent must be taken. Okay, and by many on abdominal examination is done to exclude any masses, and when the mass is present, when in the abdominal examination is performed and there is any abdominopelvic mass or abdominal mass, then we try to assess its size, site, surface and tenderness. All of this should be recorded. And on pelvic examination, bimanual examination is done and speculum examination is done, and as I told you, special consent has to be taken in case of unmarried patients. What further investigations should be performed? Ultrasound is the most valuable non-invasive investigation in depicting gross pelvic pathology. It can diagnose congenital abnormalities of the uterus, fibroids, tubo-ovarian mass, intrauterine contraceptive device can be easily localized, and in adenomycosis the uterus is enlarged, and an experienced sonologist can pick up an endometrial polyp. Okay, especially in the transvaginal ultrasound. And ultrasound findings in pelvic congestion syndrome are enlarged uterus, ovaries and pelvic dilated vein. So ultrasound is the most valuable investigation here. Then the second option is laparoscopy. The second option is laparoscopy. The second option is laparoscopy. It is the investigation of choice. Okay, but in patients who are suspected of endometriosis. Okay, see, where no gross lesion is detected, or when the nature of lesion is not clear on ultrasound, so it is the laparoscopy is the definite way of diagnosis endometriosis and pelvic congestion syndrome. And uterine abnormalities, fibroids and other tubo-ovarian lesions can clearly be seen on laparoscopy, but it is an invasive investigation and should only be performed when the possible benefit is obvious. And blood test, CBC, is especially hemoglobin, should be performed in patient with associated menstrual problem. Okay, then moving on to the treatment. The first drug of choice is prostaglandin synthesis inhibitor. The use of non-steroidal anti-inflammatory drug, that is mefenamic acid and ibuprofen, is based on the theory that prostaglandins are involved in the etiology of primary dysmenorrhea. As I told you earlier, that prostaglandin E2 alpha and prostaglandin F2 alpha and prostaglandin E2 are involved in primary dysmenorrhea. So the drugs not only interfere with prostaglandin synthesis but also block their effect on the prostaglandin receptor in the uterus, and they show an effective relief of dysmenorrhea up to 70% of patients due to their anti-prostaglandin and direct analgesic effect. And mefenamic acid is given in 500 mg TDS 3 times a day. Keep in mind that gastrointestinal upset is seen, GI problems is seen when we give prostaglandin synthase inhibitor. Then the second option is combined oral contraceptive pills, COCPs. Primary dysmenorrhea occurs exclusively in ovulatory cycle, and this drug is believed to relieve the symptoms by causing an ovulation. That is very simple, but it is not given to patients who wishes to conceive. So when prescribing oral contraceptive pills, the contraceptive effect must be explained. And the next medicine is calcium channel blocker. Nifedipine is given, and the dose is 30 to 80 mg daily. It relieves dysmenorrhea through decreasing uterine contractility. Because of the side effect, headache, hypotension, bradycardia and constipation, it should not be used if the above treatment, it should only be used if the above treatment is ineffective or a patient does not wishes to use combined oral contraceptive pills. Then the next is beta receptor stimulant. Terbutaline has shown to relieve dysmenorrhea by increasing the blood flow to the uterus, but it is not used as a routine drug because of its cardiovascular side effects. Okay, and then we can guide the patient that she can give local heat to the site, which has shown to relieve dysmenorrhea in most of the patients. And lifestyle modification, exercise, low fat diet, relaxing techniques, yoga has shown great benefit in patient with primary dysmenorrhea. And treatment of the underlying cause should be done. If the patient has pelvic inflammatory disease, antibiotics are prescribed. If endometriosis, COPs, COCPs, progesterone, GnRH analogs, and relief of obstruction is done surgically. So if you have any question related to this topic, you can ask in the comment section down below. Thank you and Allah Hafiz.